Good evening, good afternoon, and good morning to all of you, wherever you are connecting from. I would really like to very warmly welcome you to this webinar, which is the second in a series on mental health and COVID-19 that is brought to you by United for Global Mental Health, the Mental Health Innovation Network, the Lancet Psychiatry, and MHPSS.net. This webinar, as you might note, is being recorded, and you are invited to tweet your comments using the hashtag COVID-19MH, all one word, no dashes. My name is Ananda Gallappatti, and I'm the co-director of the online platform MHPSS.net. We are particularly excited about today's webinar because of the overwhelming demand that we at MHPSS.net have experienced in the past several weeks from practitioners seeking guidance and materials for mental health and psychosocial support of frontline healthcare staff who are working in COVID-19 contexts around the world. In fact, in the first 3 weeks of the response, the most downloaded document on our site, in the context of over 100,000 page views on average every day, was the early Red Cross guidance on how to support frontline healthcare staff. We're now receiving requests on how general guidance can be adapted or contextualized, as well as for examples of specific ways of integrating MHPSS considerations for health staff within the COVID-19 response, which is precisely what today's webinar is about. Therefore, it's my pleasure to welcome you all, but also to introduce the chair of today's panel, Shekhar Saxena, who is the Professor of Practice of Global Mental Health at the Harvard T.H. Chan School of Public Health. And prior to that, as many of you know, was the director of the Department of Mental Health and Substance Abuse at the WHO. Over to you, Shekhar.
Thank you very much, Ananda, and a very warm welcome from me also to all the participants and also to the panelists. Thank you for inviting me to moderate this session. I am saying not cheering because actually I'm standing. But I really want to welcome you and thank you for this privilege. As most of us are being asked to stay at home, there is a certain population that is actually asked to go to work. Not only go to work routinely, but to actually work additional hours, day and night, and I refer here to healthcare providers who are at the front line of our health response to COVID-19, which is affecting millions of people, has already infected a very large number of people, and sadly has resulted in a very large number of deaths also. It is now present in all regions of the world, and healthcare providers are at the front line of confronting this major pandemic, which has been supported and named so by WHO. When we refer to healthcare providers on the front line, we refer to doctors, we refer to nurses, we refer to the emergency health staff, technicians, even the ambulance drivers, and not to forget the primary healthcare providers who are in the front line as always, but during the current times, they are providing services to identify people who might be having COVID-19 and channeling them to the right health facilities to look after that. These healthcare staff are at tremendous pressure. They are also very seriously stressed, and in some cases having excessive anxiety and depression. Let us examine to see what are the factors that are responsible for this excess impact on mental health and well-being. The first one is, of course, the fear of infection to themselves. And it is true that they are at a much higher prevalence of and risk for infection to themselves. In fact, all over the world, statistics are suggesting that the death rate amongst the healthcare staff is many-fold compared to the general population. So this fear is there, and this fear is clearly very valid. There are enough reasons for having this fear. There is also the fact that they are working overtime and they are working in situations which in many cases are extremely demanding and not being supported enough by their healthcare administration, and also not being provided enough opportunities to keep themselves safe in terms of the PPEs, as they are called, the personal protection equipment, to whatever extent it is applicable, and also to provide the infrastructure which can help them to care for their clients, for the patients, in the best possible manner. Sometimes there are contradictory and confusing instructions given to them, sometimes changing from day to day and sometimes from hour to hour. And it is very difficult to keep up with the instructions that are coming so rapidly. They are obviously working additional hours with inadequate time for rest and sleep. Some of them are not sleeping at all for nearly 24 hours. There is also the fear of infection to their families. If they're going back to homes, there is a tremendous fear that they might be infecting their parents, their spouse, and their children. There is also the lack of nutritious food and sometimes very practical things like transport, like child care, and like housing. Some of them are actually staying in the garages, sometimes under the tree, so that they don't infect others. And also there is lack of timely information and feedback on their performance. Have they been able to be very helpful to the healthcare system, to their patients? And sometimes people forget to give them the kind of feedback that motivates them to work harder. So the next question is, what can we do about it? And a recent brief report from China actually has summarized what can be done in a very neat way, in a very parsimonious way. It says what they need, and this is based on direct information from healthcare providers. What they need is protect me, hear me, prepare me, support me, and care for me if there is need. And this really neatly summarizes what they need from the community as well as from the healthcare providers. However, we have a very distinguished panel who is going to help us to understand what the situation is all across the world. And our panelists come from all parts of the world. So we have a really, really global panel. And we look forward to hearing from them as to what their experience is and how they are keeping up with the pressure to provide the best possible assistance on mental health and well-being to the people they are in touch with. In many cases, they are directly providing help to healthcare providers as a part of their work. So I would like to welcome all the panelists, and I will just name them here briefly, and you can find more details on the website. So the first panelist is Aiysha Malik from WHO Geneva. Then I will invite Beatriz Rodriguez Vega from the University Hospital of La Paz in Madrid. Then I will invite Mohammad Elshazly from UNHCR, whose much of the work was in Rohingya refugee camps in Cox's Bazar in Bangladesh. And lastly, but very importantly, I will invite Eliza Cheung, or Cheung rather, from Hong Kong Red Cross branch. So this is our distinguished panel. And to begin with, I would like to invite Aiysha Malik to give us a summary of what are the key actions that are needed in countries to support the mental health of frontline healthcare workers, remembering the WHO is at the forefront of this fight against COVID-19, and WHO's guideline is something that all of us need to be very aware of, not only on the COVID itself, but also on the mental health side. So Aiysha, the floor is yours.
Thank you, Shekhar. So yes, indeed, WHO has advocated from the beginning that mental health is a core aspect of this pandemic. And within this, we're advocating for key populations, one of which is indeed health workers. Now, health workers are a group who already, outside of a pandemic situation, are already a group who experience poor mental health. This is both a very rewarding but also very challenging occupation. And why is this important, and why is this something that we want to raise? Well, high stress, poor mental well-being can affect how well healthcare workers are able to work. And this is a critical issue now, more so than ever. Through no blame, this can mean poorer quality care, increased likelihood of safety breaches or accidents. These are not just work consequences. This is something that impacts the actual health of health workers themselves. At its absolute worst, it may mean that health workers feel unable to return to work, or indeed those who become infected may feel unwilling to continue. So the health of health workers is key to this response, their mental, their physical, their social health. And protecting the mental health can be seen as a life quality saving measure for themselves and for patients. So countries, policymakers need to invest and prepare to protect the mental health of health workers, and to think not only of the response now, but to prepare for the long term as well. These effects will not go away when the pandemic ends, and we need health workers now, and we need them after. At WHO, we are growing emphasis on the message of protection of health workers is paramount. So this is a cross-cutting issue. There's been great focus, and importantly so, on infection prevention and control. But the protection of health workers involves many fields, including occupational health, including human resources for health. So this is pertinent for mental health planners to consider, given that these areas are likely already well integrated into health facility systems. So now is the time for mental health to prepare the key actions and work within this common cause of protecting health workers. So I will give a brief flavour of some of those key actions, and I think my colleagues on this panel will go into further detail. At one level, we think of the health workers themselves. This is not a helpless population. There is much that they can do as well to look after their mental health, but this is of course easier said than done. And our role in mental health is to remind them of measures, adapt them in a way that works for them, and make them aware of the substantial difference that this could make to protect the whole of their health. And this can include accessing psychosocial resources or stress management resources as well. And I think there's been a huge plethora of tools that have been released, and indeed WHO will release imminently a stress management tool that can be used by anyone, but also health workers. And in mental health, we may be used to dealing directly with an affected population or a patient, but when it comes to workers, we have to think about the whole system as part of their care. So it will not be sufficient only to have health workers look after themselves. Health managers, their leads, supervisors, the facilities, and even peers play a vital role. And there are very practical work-based approaches which can be considered at this level. And this can range from things like buddy approaches, pairing new staff with more experienced staff, implementing peer support systems, providing an avenue where staff have a chance to discuss some of the ethical dilemmas that they are facing in this particular pandemic, rotating staff from high to low stress functions, encouraging breaks and rests where possible, or sufficient breaks between shifts, and ensuring that the mental health aspects are included in part of pre-deployment or preparation for new staff. To do all this well, managers or peers will need the communication skills that are necessary to foster a sense of team cohesion. And there are many trainings or platforms where skills can be gained, but the principles of approaches like psychological first aid are relevant here, and team cohesion is an important part of getting through this response together. And just to add to that, the WHO will be developing training which integrates both occupational health and mental health aspects for use by health workers and their leads. And this could also be a useful resource for the mental health workforce, who may need to be upskilled in occupational procedures, as this will be a new way of working for the mental health workforce. Ultimately, mental health and psychosocial support should be available for healthcare staff, and there should be a mechanism, a clear mechanism for frontline staff to be able to access this if they need to, and to receive the evidence-based caring in the context of a crisis. The role of mental health staff can be broader, beyond providing that support directly to staff. It could be providing the support to managers, providing the support to those who are doing peer support, and advocating for minimizing the risks at work which exacerbate stress. And of course, all of this is in the context of adapting delivery to remote care. And I think that will be covered in a future webinar on this series. Just a couple of final special considerations. This is a population who struggle with help seeking. There is a great deal of self-stigma, not just in health workers, but other working populations, of expressing distress whilst in a work context, and concerns about the ramifications this might have, or the perceptions from colleagues, and concerns about confidentiality for accessing mental health support as well. You know, where will records be maintained? Will this affect my job performance? This is a barrier that does need to be addressed, and something to consider when planning care for health workers. Shame and guilt from ethical dilemmas, I think, have come up as psychological or psychosocial aspects that are key in terms of the distress that healthcare workers are experiencing right now. And I would be remiss to not mention stigma, violence, discrimination, harassment, which has been reported. And this is an area where public communication has a big role in ensuring that we are protecting health workers so that they're not further worsened in their distress by the impact of stigma. I think finally, just to note that health workers are not a homogeneous group. They can be newly qualified with years of experience in many different job roles with hierarchies within that, whether it's assistants or nurses, as Shekhar was mentioning at the beginning, or they may be working in fragile settings, humanitarian settings, or high income settings. So early studies that have come out from China during this outbreak suggest that mental health outcomes might differ for different health workers. And we really need to enhance our understanding.
Aiysha, we need to move on. Would you like to wrap up now? We need to move on.
I would. Yes, I would just say the final point is just understanding what works for who, how it works, and encourage the sharing of innovations for health workers between countries. Thank you.
Thank you so much, Aiysha, for giving us a summary of what WHO is recommending, which is important for all of us. We go now to Beatriz. And Beatriz, you're working in a large hospital in Madrid, and we know that Spain has been one of the countries that is very seriously affected by COVID. So what we would like to know is what approaches have you been able to put in place, and to what extent they have been successful in protecting the mental health and well-being of the health staff. Beatriz, please. Are you mute?
Yes. Can you hear me now?
Yes.
Yeah.
We can.
I said that thank you, Shekhar, Ananda, and all of the organization to facilitate this space to share our experience. I would like to share our experience from Madrid in La Paz Hospital, La Paz University Hospital, which is one of the biggest hospitals in the city. And we are working in the real time of the outbreak with the frontline health workers. And we found a lot of challenges working with them because frequently the managers and the own professionals are not the consideration of the self-care as a necessity, but a luxury many times. And the shame and the guilt that Aiysha mentioned to ask for support in mental health is also frequent. And the shame to have more difficult feelings like fear or anxiety or the wish to escape from one situation. And from the frontline workers, we found that they are frequently in a state of mind rushing on the action mode, and it's very difficult for them to be in touch with their own feelings and make some breaks during the work time. All of that is a challenge to work with them. For that, we designed a very simple intervention, very short intervention, 5 to 10 minutes, between 5 to 10 minutes of mindfulness-based emotional regulation for the health workers. We deliver this intervention twice at least a day, and we think this intervention can fulfill the function to be the way to care for our companions, and also the way to teach some strategies for the self-care. Also, the intervention was open to all kinds of professionals, and was defined as not as therapy, but as training. And for that, we think it was more accepted for them. Also, during the session, it's a very good space to have the opportunity to see some professionals that are in a very special vulnerability state, and to offer them some more mental health support. I'll go on to detail a little bit more the intervention, the structure. From the start of the outbreak in Madrid, we went to the site of where the workers are working. No? To do that on site, to offer this intervention on site, we found that it's very important to increase the visibility, and also to give the message that the mental health team is close to the team and sharing the same difficult reality. The first time we present the intervention to a new team, we give them an explanation. For instance, the explanation was based on the need for the self-care, because the workers, the professionals, are the more valuable means that the system have to overcome a crisis. And also, the second justification was that in an emergency context, is very important to train the mind, to train the emotions at the same level. Other trainings, as the putting on or taking off the equipment, the protective equipment. The common goal for us was to facilitate, to cultivate an inner space of calm in the midst of the storm. And in the intervention, I said before, it was between 5 to 10 minutes. In the intervention, we trained 3 kinds of elements: attention, focused attention, a set of conscious movement, and an attitude of compassion and self-compassion. We found also that this intervention was flexible in the sense that if we found to a intensive care unit and we found the team very hyper arousal, it's easier to start the intervention with the set of conscious movement and kindly slowing down the rhythm and to finish the intervention with the focus awareness or the compassion. The intervention.
Thank you so much. We would like to, of course, know more, but maybe I can come back to you, and we need to move on now. So I would like to, and also thank you for pointing out that these are interventions which are being offered as promotion and not as a therapy, which I think is a very important point that you made. I'd like to move on now to Mohammad. You have had the distinct advantage of working in two very different settings, in Bangladesh and now in Egypt. So can you tell us something about what the essential elements of this help that you have been able to provide have been, and what are the critical differences between these two settings? Mohammad, please.
Thanks a lot. Thanks a lot, Dr. Shekhar and colleagues. Indeed, if I start about the humanitarian response in Rohingya camps in Bangladesh, I would just like to highlight that specifically the health staff are exposed to a higher level of stress and trauma, especially in this protracted emergency. And this trauma can be either like a primary trauma from direct exposure to stressful adverse situations, or second trauma as well from exposure to experience of others. And some studies suggested that up to 70% of the humanitarian aid workers may experience mental health problems related to their jobs. And in particular, we can say that health staff have a higher risk of burnout, depression, and PTSD, and which sometimes continues like 3 to 6 months after their assignments are completed. When looking at the both contexts and the Rohingya camps in Bangladesh and in the situation in Egypt, they are quite different. I can see there are some common challenges to both contexts, like what colleagues have already mentioned. The stigma around mental health and help-seeking behavior. You know, in these emergencies, we have the culture of heroism. You know, like we are here, we are to save people's lives, and we don't need any support, and we don't really acknowledge that we have our own mental health needs. And sometimes this attitude is reinforced by organizations as well, of course, by being committed to provision service for people in need and having less availability of support or space for people to express their own needs. Also, we have a lot of challenges related, you know, to lack of institutional policies and capacities and responses, you know. So despite the guidelines exist, but rarely they are applied. In Bangladesh specifically, I think we have quite some operational challenges. One of them is the pre-existing actually workload and experience. So the health workers are already being overstretched. They have been responding to many outbreaks in the last 2 years, like diphtheria, measles, chickenpox, and cholera outbreaks. It has its own positive and negative side. So from a positive side, it gave a lot of learned lessons and a lot of resilience for the healthcare system and how to deal with these pandemics. But at the same time, it brought a lot of exhaustion to the health workers, and they move already to respond to this emergency with preloaded psychological distress and overload. Also, another added challenge is that the healthcare system is mainly built around primary healthcare services, which means we have a lack of specialized human resources, and we have complicated referral pathways to the secondary care, which is a challenge now. So we have to run quickly now in order to strengthen the secondary care level. Also, in general, in humanitarian emergencies, and specifically in the Rohingya response, we can see there is more attention to the mental health needs of the expatriate international staff rather than to the local health staff. Also, the perception of limited resources, especially the PPE kits, is one of the major concerns of the health workers. When it comes to the specific challenges in Egypt as a context, of course, the population size, we are talking about more than 100 million people, and it's more of unprecedented experience for the health staff as well to deal with compared to the one in Bangladesh. In terms of what we can do briefly, I would like to categorize this into 3 main categories. The first one is the pre-assignment preparation and during assignment response, and the third one is the post-assignment follow-up. we have been working in how to prepare a pre-assignment orientation pack or a training that includes preparation for the health workers about the potential risks and how to respond to them, include contents related to psychological first aid, team building, as has been mentioned by Aiysha and others, self-care measures, and some physical exercise, mindfulness techniques, breathing, and relaxation. So we try to build this as one orientation package, put it in multimedia, like video recording, and share it widely with healthcare workers. We included some content about how to communicate with patients and their caregivers, because this was perceived as a concern by the health workers, how to communicate effectively with patients, and how to manage their own anxieties. During assignments, we are working during assignment during their work in hospitals and primary healthcare centers. We are trying to provide more of remote support, counseling service, use helplines, and e-mental health programs and self-help guides. And I think what's most importantly to look at is post assignments and the follow-up after that, because according to most of the studies, that sometimes this stress continues for 3 to 6 months after assignment, sometimes, or mostly it's overlooked and not looked at. In Egypt specifically, a dedicated task force stemmed from the National MHPSS Coordination Group and includes all the relevant NGOs, ministries, and individual initiatives that aim to support mental health care workers. In Egypt, of course, we have more resources compared to refugee camps, and we have more specialized service, and they are being organized now in a way to provide adequate support for the health system. I hope that's it from my end.
Thank you so much, Mohammad, for giving us two perspectives, one from Bangladesh and another from Egypt, and also for making the point that sometimes the countries that are poorer but still have had a long experience of facing humanitarian disasters can actually be better prepared than some of the richer countries that may not have had the experience of working in this area. So that's a very important point. Thank you also for being time efficient. And then we now go on to Eliza to tell us more about the situation in Hong Kong, with the perspective that is now in a way having more experience in terms of time, because the pandemic started from China. And so tell us how you have been able to handle it, specifically from the perspective of mental health and well-being of healthcare providers.
Sure, thank you, Shekhar. And I'm Eliza from Hong Kong Red Cross branch, and I'm also part of the IFRC Reference Center for Psychosocial Support. And I'm very glad to know it from Ananda just now that our earliest, one of the earliest publications on the MHPSS for COVID is one of the most downloaded documents at the mhpss.net. Is definitely like it was said about like early February, because basically Hong Kong also like faces outbreak a little bit earlier. So far, I mean, at Hong Kong Red Cross, we have been providing some direct service to the public, including the healthcare workers, using some approaches like psychological first aid. And we also developed a lot of information, education, and communication materials targeting health workers and distributing to like hospitals, some medical associations, some trade unions. And we target not only to doctors and nurses, but also to other allied health professionals, to some healthcare assistants, or even lab technicians, because their work could also be like exposing themselves to the risk of the infection. And these IEC materials has been adopted and translated by quite a number of national societies in different languages within the Red Cross and Red Crescent movement. And when we distribute these IEC materials, a lot of health workers feedback to us that some messages that we highlighted, they found it like most relevant to the situation. They include when they say that we remind them you're also a human being, and taking good care of yourself is also like being responsible, one of the ways of being responsible to others. And then to understand your role, to evaluate your responsibilities and risk, and also take time to make the decision. They said that like knowing about these messages also alleviate their burden of some of the internal struggles that they are having, and it's like having this kind of like decisions, struggles, or even like considerations are actually like normal human reactions in these situations. So I think this this message to us is really like relevant. So at the beginning of the outbreak, at late January or early February, I guess in Hong Kong, it could be because of the impact of SARS back in 2003 that we respond in the SARS outbreak here. We have quite a number of health workers got infected, and we also lost some of them. It definitely like stuck in at the back of the mind of a lot of health workers, and that's why at the beginning of the outbreak, people are I would say quite panicked because of that, and also because of some of the shortages of the PPE and other like mask or alcohol rub. We also know that some like private clinics, they are not able to open because the doctors and nurses, they don't have this equipment ready for them. So I mean, at the beginning, it's definitely quite chaotic, but I would say it's already like 2.5 months down the road for now, the situation in Hong Kong. A lot of health workers told us that they realize it's not like a sprint, but like a marathon in responding to the COVID. And that's why they are also gradually adjusting to this new normal life. Of course, they are still facing a lot of stressors, which definitely like we need to support them in better ways. Like there's the shortages of some equipment or like shortages of some manpower. But then they also have found some of the ways to cope with these situations. Just now, Aiysha also mentioned that like the health workers, they are afraid of infecting their families because of their work. We also like have similar situations here in Hong Kong, and I bet all over the world. Some of the like medical workers, they try to like rent a place so that they can stay there temporarily instead of going back home, or put the children to their family, other family members for them to take care of, so that they don't like really spread the virus to them. So I mean, for now, I would say that I really appreciate how our health workers have been doing in Hong Kong. So far in Hong Kong, we don't have like serious like nosocomial infection within the hospital, because they work very hard, and they also try very hard to like maintain the hygiene and everything. But one of the lessons learned when we are working with them is that of course, we have some hotlines, we have different like other supports or like self-care, but it's very important for us to know that, especially some of the panelists also mentioned earlier, they can't just like survive like using a lot of self-care methods or how to cope with their own stress. They also need support from other people. Sometimes they may not feel like they really want to talk to someone at the hotline or to a mental health professionals. Instead, what they want is really like the care from their family and friends, to talk to them, and also the care from the employers, particularly like the arrangement in the hospitals, the work shifts, and like how to arrange the work, and also do they really have a say or contribute to some of the decision making, like within their service. Although a lot of people would say that it's probably the work of some hospitals administrators, but involving like frontline workers into decision making also like enhance the sense of like control, and also the sense of like involvement in the whole situation. So I would say these are some of the lessons learned that we learned from the health workers who talk to us, and also feedback to us onto some of the materials that we prepared.
It's a wealth of information that the panelists have just now shared with us. I would like to ask a few questions to maybe each one of you, and just kindly reminding you that keep your response to 1 minute or less so that we can finish in time. So the first question is to Aiysha. You mentioned about the imminent launch of a stress reduction program by WHO. Tell us a little bit more about it, and also to what extent is this evidence-based?
Thanks, Shekhar. I almost don't want to steal the credit for where this will get discussed in a future webinar. It is based on evidence. It is going to be in the format, it currently is in the format of a book that is illustrated, and the plan is to move it into a digital mode. And my colleague, I believe Ken Carswell, will discuss this in a future webinar.
Thank you so much for sharing this information, and that's also an invitation to all participants to log on and continue to participate in these webinars. More to come. So I go on to Beatriz, and my question to you is, evidently, the interventions that you are starting to do have had a positive effect on the healthcare providers. But to what extent these interventions have been welcomed or not by the hospital authorities? Did they feel that you're doing a job that is required, or did they feel that you are distracting them from the most important care for patients with COVID? Beatriz, please.
You mean for the authorities, the managers and the people and the health workers?
That's right. Yes,
We,
the managers,
the managers are welcome at the intervention because we have experience to work with them in the Ebola crisis 5 years before, and we work in a very similar way. And the workers are welcome at the intervention. More than 500 workers are participated in at least one session. And we didn't have any adverse effect and serious adverse effect. And they rated the intervention on a scale from 0 to 10 as a median of 9 in the utility to decrease their stress. And this is our experience.
Thank you so much, Beatriz. Question to Eliza. You work in the civil society sector. To what extent you have found easy to work with the government sector for safeguarding the mental health and well-being of the health staff? Eliza, did you hear the question?
Oh, yes, just now the internet got some problems. Yes, I think it's important that like we work together with the government, the civil sector and also the governmental sector. I would say in some context, maybe the government would take more initiative and leadership in the case management or contact tracing. At the same time, it's very important. Particularly, we know that it's a public health crisis, and it needs to involve the whole community. And that's why as NGO or from the civil sector, it's also important for us to mobilize the people in the community to raise their awareness, and also to have them to aware that actually MHPSS is also part of the pillars in responding to an outbreak response. I would say definitely in different situations, it would be quite different in terms of the difficulties and also the challenges, but mobilizing our own volunteers within the movement, because they also belong to the community, and by having them involved in the movement, they are also affecting their own friends and families and also in the communities, and it just multiply our impact in that sense. So I guess this applied to a lot of other INGOs or NGOs, grassroots organizations in different countries nowadays.
Thank you so much, Eliza. And my last question, very briefly, please, to Mohammad. To what extent has it been easy to insert the mental health and well-being of healthcare providers in the plan that Egypt is making now for COVID-19?
Well, I can say confidently that really emergencies can be seen as a political window to introduce all the concepts and practices related to mental health. So the attention to the mental health in general and the mental health of health workers has been placed really in the top priority of the Ministry of Health here in Egypt. And I can say that the Minister of Health herself and the top leaders in the ministry, they are speaking frankly about the need to dedicate more resources to the mental health for the community, for the vulnerable groups, and for the health workers. So I think it's, despite it's a disaster and the crisis, it's a good opportunity to scale up all the interventions and the concepts related to MHPS here during this time.
Thank you so much, Mohammad. In fact, you just summarized it so well that although it's a disaster, but this could actually be an opportunity to focus attention on mental health and well-being of the general population, but also of the healthcare staff, which is at the front line of this response. That brings me to the end of the allocated time. So again, thanking all the panelists, I pass the floor back to Ananda.
Thank you, Shekhar. Just remains for me on behalf of all the convening organizations to thank once again Shekhar, Aiysha, Beatriz, Mohammad, and Eliza for your time and your contributions today. To all of you who joined from around the world, I trust that you have also found the insights and experiences shared useful and stimulating, as I have done. The recordings and notes of the session today will be posted on the website unitedgmh.org very shortly, and I'd like you all to invite you all to join next week's webinar on April 21st at the very same time, which is going to be on research priorities for mental health and COVID-19. And you can register for the webinar at the same site that you did for today's. You can visit unitedgmh.org to register and also to submit questions in advance of the session. So thank you from me and from all of us for joining us today, and we hope to see you next week. Thank you. Bye-bye.
Thank you.